Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. My name is Terry Fletcher. Hope everybody's having a good October. Looking forward to Halloween with the kiddos or even some adult parties that are out there coming up. I can't believe we're almost to the end of October already. This is crazy. Usually what we do on the last Tuesday of the month is we really get into my top 10 questions that I've had on coding. I am going to have some coding questions, but I wanted to focus on something else because usually what comes up as I work through my business, and the last couple of weeks have been about auditing and training and more training for staff members. I wanted to give some tips on beginner medical coding and just making sure that some of those new coders out there, and even the seasoned coders that need a refresher, you just know what it's going to take. And I'm going to include some salary information if you decide you want to go into maybe a different branch and work in your way to coding. But there's just some things that I noticed that could be helpful to some of the newer coders out there that needs to be said today. So I'm going to get started with that, and hopefully you'll find this information helpful. I know we did, I think it was episode 49, where I did something on how to break into the coding field. Well, now this is, now that you've got that job, or at least potential job prospect, I just want to give you some tips on what to do with that opportunity, and hopefully that will help you in your coding process. Okay, so first of all, the Codecast Podcast is brought to you today by Advanced MD, spotlighting telemedicine as a solution that's proven to boost patient engagement and bring in new revenue streams for your practice. AdvancedMD.com. And Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. HealthcareExecutivesNetwork.org. Okay, so where do I want to start with this? Well, first of all, I wanted to let you know that we now have 37 countries listening to our Codecast podcast, which is just phenomenal to me. We have about 22,000 listeners, 23,000 listeners in the U.S. We have about almost 25,000 total, and we are now in Germany and Canada, Sweden. I just want to name a couple of these and give them a shout out. UK, Japan, India, Australia, Turkey, Kenya, Switzerland, Mexico. Let's see, what is the other one we're at? New Zealand and Ireland. Ireland is very high tech jobs. So, and a lot of the U.S. Companies work out of what they have in Ireland. So it's great to have them on board as well. But just thank you to everyone who, not only in the U.S., but also abroad, that really gives us some fuel to keep going with our Codecast podcast. I love doing this. I really do. I look forward to it every week, and trying to come up with some topics that you will find interesting and want to keep listening in. And I've had a lot of positive feedback, so I appreciate that from everyone. And hopefully this week is no different. So tips on beginning medical coding. So a couple of things. I'm going to throw out a couple of statistics just so you know where medical coding really is, not only in the healthcare industry, but with the Bureau of Labor Statistics. So they put out a lot of things when it comes to where the job market is. You know, a lot of kids coming out of high school, or people coming out of college, and just people maybe looking for a job change. You know, is it a viable industry, and is it growing? And so, yes, it is. As the population is aging, the need for medical coders and billing professionals and medical records professionals, all of that, it's really important field. It's really an important field to get a job into. So the Bureau of Labor Statistics says that they expect this field to grow by 21% through 2020. And that's a rate much higher than the average healthcare industry job. Breaking into the medical coding business is not difficult, especially with the demand for skilled coders so high. But because coding is such a detail-oriented position, and the coder's work affects nearly every area of the medical practice, a novice coder can quickly get overwhelmed. And I understand that, especially in some of the training I've been doing this week. So when beginning a medical coding career, there are several tips, several little things you want to keep in mind to make the job easier and hopefully make your work better. So the first thing I'd like you to think about is learn the specialty. So new medical coders, you often come out of a generalized education program. So this is a good foundation, but if you're working in a specialized practice, such as radiology or cardiology or orthopedic surgery, and oh my gosh, general surgery, any of those specialties, you'll most likely will need to really dig deeper to understand some of the subtle coding nuances for that. I found that out this past week as I'm multi-specialty, but it's hard to you have to regroup once you're, I would go from cardiology training and then I'd have to go, okay, now I need to regroup and rethink. And now I'm doing my orthopedic surgery training, and I've got some subspecialties like spine and foot and ankle and hand. And then I moved over then to some rheumatology. Then we talked a little bit about radiology. And so it's common for a lot of these procedures, not only in the office, but in the hospital, to carry multiple codes. And sometimes the office staff kind of takes for granted that new coders know what those procedure codes are and ICD-10 codes without any training. In a training course that I was conducting last week, we had both seasoned coders and the new or potential new coders, some that were moving from medical records to coding. And the seasoned coders, I noticed they had a lot of questions on things they already had a point of reference on. So they're like, okay, Terry, so we have this patient, and can you answer this question? But I noticed that the new staff really didn't have a lot to say. Now, I know part of that silence is because they were taking it all in, and I appreciate that. Part of learning is listening. But part was because they really didn't understand some of the concepts as I figured out, and it was a very informal roundtable discussion, not to call anybody out. But I did query some of, the newer coders, and I said, let me ask you a couple questions with your job. And some of the questions I asked, a lot of the responses was, I really don't know. So I decided to go back to basics, even to what is a new versus established patient, talking about the 3-year rule. If you haven't seen a patient within 3 years under the same group practice, same group specialty, then it's considered an established patient. But if a 3 years has passed, then you could possibly capture a new patient visit, even if you're under the same tax ID as one of your other specialists. Difference between a non-displaced and displaced fracture care. One could require manipulation, one could just require casting, and there's a difference, and how the modifier 25 can help and possibly hurt you. But spend time with the practice manager, learning about the flow of the office and standard procedures so that you do not miss any codes that can prevent the office from being paid properly. If you were hired, for example, in an orthopedic practice, and again, we talked about that fracture care, is the office billing the global fracture care code when a simple non-displaced fracture is a problem, meaning that it's maybe a hairline, it's not completely broken? Or are they itemizing out the office visit, casting, strapping, supplies to avoid that global day return, meaning that if you're billing out like it was a surgery, which you can, there's generic fracture care codes, then when the patient returns to the practice, they can't bill for an office visit because it's included in that global service. So knowing the flow of the practice and learning the specific specialty, and those were just a couple of examples that have some nuances to that specialty. You get into cardiology, and is your group one that always has the patient come back for an EKG every time they come in? Well, you have to have medical necessity for that. It's not for every patient. Or are you a HENT physician, and you're dealing with issues that go outside that area of the head, ear, nose, and throat. So knowing what the specialty is and really understanding not only terminology, but just the basic clinical is going to be important. Look at previous coding. So this is another one. Pull the previous super bills, or if you're on an EMR or electronic health record, look at the patient ledger, and also look at the claim forms for the most standard office procedures and see how they've been coded in the past. So do not assume that the codes are correct either. Review the procedures done against the medical record and perform just your own mini audit to see if you would have coded the record the same way. So put those codes down, write them down, or put the claim form to the side, and then look at the report and then say, okay, how did they not only pull this out of the report, extrapolate those codes, but would I have coded it the same way? And that's going to be really helpful to you, not only as a reference guide in the future, but now you can kind of see how other physicians are dictating, documenting, and what you'd be looking for in the future. This can just give you a solid idea of normal office flow and procedures, and then note any discrepancies and discuss them with your practice manager. They know you're a new coder, so they're going to expect questions. And actually, new coders that don't have questions tend to worry me a little bit. I want to hear the questions. Now, if the same questions are being asked 30, 60, 90 days later, the exact same questions, then that's going to be an issue. But you want to make sure that you have proper training, and sometimes it's self-teaching, but with the help of putting it out there and asking some questions. Another tip would be to review the explanation of benefits. So those are and review the contested or unpaid as well as the paid. Those are the attachments to what the check comes in, or if you're getting paid electronically, which most practices are, that is the itemization of what was paid by the payer. And you want to see if a coding error was to blame for any unpaid explanation of benefit or contested claim. Often transposed digits or simple coder error created the problem. And so if you're already in your coding position, just fix the error, resubmit the record for payment. You might have to do a reconsideration form. But discuss the large scale items, any unpaid EOBs with the billing and office staff, and also your CBO managers, your central billing office manager, because you're trying to ensure that you're all working as a comprehensive team to get every procedure paid as quickly and as accurately as possible. Inquiring about this and inquiring about certain services, this is only going to help the practice as long as you're not taking it to the extreme on every single procedure because you don't know it, but it's a way to just review, okay, so when I submit it this way with this modifier, with this information, this is how it gets paid or denied or contested, and I have to figure out how to work it. And some practices, it's interesting because the coders and the billers, they don't get to see the back end. That goes to the collection office. I like seeing the back end. I think that's one reason why I've been successful in my business is because I care if something gets paid, if something gets denied. I actually find it to be kind of therapeutic and a challenge, and to figure out, well, how can I talk to a payer about this? How can I let them know that this is what I want to get? And actually, just a side note, I had a pretty awesome kind of validation of what I do this week. And it doesn't come up often. So you kind of want to shout the rooftops about it, but I'll just give it in a generic sense as to not say anything about an office and violate their privacy. But I do have a client that was struggling with a rack audit, and they were looking at about a $287,000 refund. And so it was very unfair as far as what the rack audit was doing. And when I was reviewing the notes and also reviewing the records in the hospital, I could see the disconnect. After 30 minutes of reviewing it, I was like, okay, now I know what happened. Dealing with pacemakers and registries and cardioverter defibrillators, so ICDs, and things like that, and just making sure that all the, I's were dotted, T's were crossed, and most of it was, but the rack auditor didn't feel that way, the company. So went and wrote the major letter, went and discussed with the practice what happened. And we did this all through electronic means. I didn't even get to see them in person. But I was hoping for a reduction and, just obviously trying to get it down at least by half. We ended up getting the reversal. They said, nope, you are correct. We've reviewed everything you sent, and there will be no monies due. The provider was paid appropriately and accurately. I mean, I did a happy dance. I haven't seen to that extent in a really long time where the rack audits basically say, you're right. And so that was kind of a nice validation. So going back to reviewing explanation of benefits, don't always take what they say as accurate. You want to fight for that physician's money. And when the practice can see just how proactive you are, if that is your role, not only in the coding and billing department, in trying to make sure that you are not only educating a payer, but trying to appeal something that should have been paid, you only have up to go when it comes to your position. The next tip would be your coding materials. So this is big for the new coder. Online access to CPT and ICD-10 coding books and materials sometimes is included with your school textbook purchases. Keep both the books and try any online access codes in a safe place. so that you can bring them to your job. If you have a paper book, yes, I am old school. I want a paper book. I still like my hard copy and I bring it everywhere I travel in the country. But you want to have quick, reliable access to these materials because it'll save you a lot more time trying to, hopefully somebody will give you a copy. And sometimes it's a shared office copy. You want your own. You don't want the frustration as you're starting your new coding position. So make these books your own by using highlighters for language within a code. So for an example, if you're in cardiology, 36221 is what we call a cervical cerebral injection. So the physician's injecting at what we call the arch in the aorta and looking at the great vessels or the carotids. I like to highlight arch because that's what the doctor will call it. I did an arch injection. They won't call it a cervical cerebral, or sometimes a non-selective carotid, but rarely. Or another code in radiology, 75630. That says angiography, bilateral iliofem. Well, if you don't know the iliacs and the femorals are in the legs, bilateral is both legs, then you would not know what that means. It also says abdominal plus, meaning that we're putting a catheter high up in the access in the abdominal aorta and with one injection and letting dye run down. And then it also says serolography. Serolography means multiple views. So again, highlighting and putting little notes of what each of those terms mean will be like, oh, okay, so when the doctor does one high injection, gives me angiographic data to look at not only the aorta, but also bilateral legs to above the knee, because that would be iliacs and femorals, then I know what code to use. So those kinds of things are going to be important. One of the basic areas that you really need to make your own are using those tabs. So in the very front of your CPT book every year, they actually have tabs we can pull off. It's just like something you'd buy at Staples or one of the business supply stores, but they give them to us. I wish they wouldn't always put they like write things on them so that you can put it in a certain section. I like them when they're blank. They have a couple of blank ones in there, but they started writing on there for us. I'm like, that's not helpful. Let us do it ourselves. But you want to tab the areas that you frequent, and also tab areas, and this is really important, areas that are out of order sequence. So one code that for some reason, I know the code, and that is pulmonary angioplasty. That's 92997. But I sometimes keep forgetting that I have to go behind 92920 because it's out of sequence. So when you tab that, then you can easily just turn to that code. And so just make sure that you understand that some things are out of sequence in CPT, and you'll try forever to try to find it, and you can't find it. Also, make notes alongside a code that you're not familiar with, but will see often. And this is why I like the paper book. I use my pen. I want it in indelible ink. I don't want it rubbing off with pencil. But an example in thrombolytic, let's say. So first day of a thrombolysis, 37211. And so you can see I'm kind of focusing on cardiovascular medicine right now. But what that is, thrombo meaning blood clot. Lysis meaning that we're trying to dissolve. So thrombolysis, we're trying to dissolve a blood clot through medicine. What I would write things down would be something that reflects the medicine the doctor's using. What am I seeing? Because the doctor's not always going to say, I did a thrombolytic or lytic therapy. They're just going to say, I injected how many cc's of TPA or integralin or alteplase or heparin. So those kinds of things, you just want to write it down going, oh, if I see that to dissolve a blood clot or a thrombus, then I know what that is. I've talked a little bit about moderate sedation at times, 99152. And you want to put things down in there like propofol. No, that's a sleep aid. But Versed or midazolam, which is the generic version, yes. So some things like that can help you when you're looking at a report. But whatever helps you best understand, and remember, just do it. It will help you later when you decide to take your exam, if you haven't taken it yet, and on the job, because now you own it. You own the materials, you own what's in the materials, and it'll really help you. And then as we look to salary information, everybody always asks me this, so I pulled up some statistics just so that you have it, and then you can kind of mull over and think, okay, is this where I want to be? What are my goals when it comes to salary? And I actually think a lot of people think that coders in the healthcare field is a little higher than what it is. And it's actually on the lower end, but you can build that salary higher based on not only how many tasks you take on, but just how valuable you become from a project-oriented position, from possibly moving into management. even consulting, and just putting yourself out there. So medical records and health information technicians, they earned a median salary of about $38,000 in 2016. That's according to the U.S. Bureau of Labor Statistics. On the low end, medical records and health information technicians earned a 25th percentile salary of about $29,900, meaning 75% earn more than this amount. But the 75th percentile salary is $49,770, meaning 25% earn more. So in 2016, 206,300 people were employed in the United States as medical records and health information technicians. So only a fraction of this number had actual certified personnel doing the job. And so I believe in getting certified if that's where you're heading with your career. I think it's important with a credible company like AAPC or a HEMA. But you want to make sure that if you're going to do that, it's something that you believe in, something you're committed to. Otherwise, just having letters after your name doesn't do anything for you. You want to make sure that that means that you're taking on a responsibility based on the Hippocratic Oath of what you're doing with that certification. It's important that you know that. I see a lot of coders that are doing things that I find suspect. And I'm thinking, why get your certification if that's your position in the industry? You want to know that you have to uphold a higher standard. And so if you're going to do that, that's the expectation. Starting pay and pay by experience. So I know I get some coders that are saying they're struggling a little bit to get a job. They're saying, well, you have to have experience. And how do I get experience if I don't get a job? I'm aware there's a little vicious cycle going on there. But according to a salary survey conducted by the American Association of Professional Coders, that's AAPC, the average starting salary for medical coders in 2012 was around $33,000. That hasn't changed significantly since 2008. However, the latest round of statistics showed that salaries increased quickly since 2012, and the most recent figure for a starting medical coder in 2017, they haven't got all the information, but the preliminary findings is $41,000. That's actually not bad for a starting person in the industry. The same salary survey reveals that coders average about 47 after 5 to 9 years on the job and can hit 50 to 65 per year between 10 and 15 years experience. And with those over 15 years experience, they average just over 60 per year. Of course, there's other factors that determine, what coders can expect to be paid, how many physicians, how big the practice is, what tasks you're taking on. And there's also the pay by region. So across the country, AAPC found that all coders made an average, this is everybody, not just beginning, of $47,800 per year. But, salaries do vary considerably by region. So the lowest salary, about $41,700 per year, was in the East, South, Central states. And the West, North Central states, they're about $44,400. And then coders working in the Great Lakes region reported about $45,200. And the highest paying regions for this occupation were New England at $51,300, the Mid-Atlantic at $52,500, and these are averages, and then the Pacific region at $56,900. And then also education does help. So as of 2014, APC reported that coders that do not have a college degree earned an average of $41,000 per year. Those who held a post-secondary certificate, so a coding certification or an associate's degree in your field, who made up over half the respondents, they average about $45,000. So it does go up quite significantly, about 10% with some kind of an educational post-certificate or associate's degree. Those who held a bachelor's degree earned substantially more at about $54,000. And then coders who held a master's degree out-earned all other categories, of course, with about $79,000 was their average. But to be fair, anybody with a master's degree usually is also going to be in health information or management, and they're more in administrative positions, consulting positions, multiple certifications in coding, but also at least 10 years experience. So you can kind of see where that salary is. But just talking about the job outlook, according to the Bureau of Labor Statistics, medical coders, medical billers, and other health information technicians, they feel should be really good as far as what's out there through 2020. They expect these jobs to grow at a rate of 21%, which is 11% higher than the average growth rate for the American economy job market. AAPC, though, did their own internal survey and found that about 23% of those holding entry-level credentials reported they were struggling to find a job in 2016, and it did get better in 17. But remember, the job does not come to you. So I'm going to just I'm going to kind of say a couple things now, and hopefully you hear me. And I'm saying this with love. I'm saying this because I really want you to find that job. But you have to go to it. Okay. How do you do that? You start by code calling practices. I know it's not the most glamorous way to get that coding job, but some practices just don't have the time to post the job on Monster or even the APC job fair site or in places. They basically go, do you know anybody? Or yes, I know I have to get to that. Or then they basically say, we're just going to wait until we hire somebody else. I see a lot of practices doing that. But if you go to them, this opens the door again for that conversation. And also put yourself out there. If you can, afford to put aside just a little bit of money for education, try to go to some in-person coding workshops to network. For example, I'm in Dallas in a couple weeks, and when I'm doing a 2-day cardio boot camp, and I noticed that when the last one I gave, I think was in Napa? I think so. No, I was in Portland. When I was up there, I noticed that there were several people there that said, yeah, I'm still looking. And there was a physician that came, and he's like, you know what? I'm going to hire you. And so because they were proactive, they were getting their education on coding. And then I mentioned some of those online sites such as Monster and job.com. But, these sites tend to weed out good candidates because they can only assess what you are on paper. And when I say put yourself out there, not just taking the in-person coding workshop, but go to chapter meetings for APC and AHIMA. Find them. They'll go to their website. They'll show you where the local meetings are. They're free. And that way you can network as well. And this is the biggest thing. If the coding job you want, the perfect job is not out there, choose to start in a different department, maybe billing or medical records or even front desk. Yes, I know front desk is tough, but then work your way into the coding position. Once the practice sees that you're overqualified for another position, you could open a window, or you could decide that, wow, I really like being at the front desk on the front lines with the patients, and maybe, that would be a possible management opportunity for you, or a branch of the medical office that you didn't know you'd like. And last, I'm going to say something that sounds weird, but be nice and positive, especially on social media. I'm very active on LinkedIn. I post the Codecast weekly, and also some articles I find to be helpful for people. And then occasionally I'll just post a calming picture, because we know that not just physicians, but staff are heading towards burnout as well. But complaining about your lack of job or how a certification entity hasn't helped you get a job, it just shows you as a complainer, and that you're waiting for your big break. It also shows a potential employer that you have limited skills of appropriate and propriety when it comes to job fair and job market. And if you don't think physician practices and hospitals are looking at LinkedIn, Twitter, Facebook, Instagram, think again. Social media, everybody looks. There's no secrets anymore. I love Instagram and Twitter, and have had more business generated through social media this year than ever before. But on occasion, I'll post my annoyance with something, because we're female. Okay, let's face it. Females are emotional and we say stuff. And immediately I'll take it down going, well, I shouldn't have posted that. Usually it's about how my daughter drank my last cup of coffee, but that's okay. But be careful. You just have to be careful with social media posting. Make sure it's professional, it's appropriate. And if you're on Facebook or you're on a platform that can be private, make it private. You don't want an employer seeing what you're posting if you don't want people digging. Also, write articles, and write a lot. A published author opens so many doors for employment because now you have name recognition. Write about what you know. And oh, by the way, grammar counts, especially on your resume as well. That's the one thing I had when I was doing some training recently in Fresno. I had a couple physicians. Basically, they were like, oh, hey, I just read an article you wrote for ICD-10 Monitor. And when I was in San Diego, they said, I just read your article in Journal of American Medical Association. At another doctor in Dallas, say, I read your article in, what was that one? Radiology Now. So when they see that, and I have another one coming up in medical economics, and I write for them often. So when you are a published author, you're a published writer, it gets you noticed. And people take you seriously because these are authoritative outlets. I write for AAPC, different entities. They want people out there that are sharing ideas, sharing information. And, the only way that other people rise up is if you help them. And this is hopefully with the platform you see that I'm doing that as well. And then the last thing I want to bring to you, again, when I mentioned the medical records and health information technician, that is a really good place to start because it'll also give you the language. It'll give you kind of like a homegrown terminology course because you're forced to look at the medical record and understand what that says. And everyone has to start somewhere. There's no elevator to the top floor coming off a new certification or just, wake up one day and say, I'm going to be a coder. It has to be earned, and earned not just in if you want to be certified, but earned in going for it. But you can do it if you have the right mindset, the right understanding of what it takes. And I know you can do it. That's something I know you can do that. This week's episode has also been brought to you by Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com for the business of medicine, digital magazine, and health IT. And so make sure you look in the month of November. I will have an article up on all the fun things that Medicare just did on telehealth. And boy, is that getting crazy or what? So my coding question is kind of interesting this week. It's not really a coding question, as it's more of a practice management question, but I thought it was interesting to bring to your attention since we're talking about everything within the practice. So the question is, my office's clinician is upgrading to a new phone and has me wondering what is the best way to dispose of a mobile device? Thank you in advance. So the U.S. Department of Health and Human Services, Office of Civil Rights, OCR, points to mobile device disposal as a key point for risk analysis for anyone whose devices, mobile or otherwise, access protected health information, so our PHI. In July, there was a cybersecurity newsletter, and the OCR recommends performing a full risk analysis and points out how much time and money such a step could save by preventing a breach. So your practice may have already anticipated the costs of services like this, but you might have to get either a legal counselor or something just to make sure that the afterlife of a device is what they call decommissioned and disposed of securely to ensure that either the devices or the media on there are destroyed and any confidential or sensitive information stored on the device has been removed. And so the process is kind of interesting. But you want to make sure you're going to your legal counsel for that because that's going to be important. And then the last thing that somebody had asked me, remember I'm kind of trying to give you a personal tidbit about myself. And this week is just about the beach. I live in what we call a very beachy community. And so it's Laguna Beach, Laguna Niguel, South Orange County area. And for those of you who know how I stay sane with everything going on and working 60 to 80 hours a week, I take my mental break at the beach. I have to, just to go and you need to get off your phone, get off everything. And I will just take that 15 minutes and just sit at the beach and listen to waves and just reflect, not just on the day, but on the family, on my friends and what's happening out there. And it just gives you that reset, kind of take the time to unplug if you can. Whatever you can focus on that has nothing to do with work, electronic devices, even sometimes your family. We love them, but we don't need them always in our ear. So just, take some of that time to do that. And that's something that I do. And lastly, I'd like to thank Keck Medicine of USC, over 500 nationally renowned physicians at a leading academic medical center, keeping you healthy, on track, and doing things you love. KeckMedicine.org, ranked in the top 50 hospitals in the country by U.S. News and World Report, and #1 in Southern California for cancer care. Next week, we're going to talk about, and it's a touchy subject, especially since I just mentioned all of our 37 countries out there, but we're going to talk about offshore subbing out and outsourcing some of our medical record information and coding and billing. And is it a good idea? I think you probably know my feeling on it, but we're going to just talk about making sure that if you do it, that you can be ensured of your compliance. And it's a really important topic. So please join us next week and know the steps you have to take to make sure that you're compliant. All right, everybody, make it a great day. And thanks for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.